Thanks very much, Nick. Welcome, Harlan, to the STAT Summit. We're glad to have you here. So the topic of this is putting the values back in values-based care. And I wondered if you could start out by telling me how you think about and what you mean by value in cancer care.
Hi, Gideon. Thanks for having me today. Yeah, you're asking the fundamental question. It's the right place to start. If you don't start with value, we really can't solve the healthcare dilemma. I think many of us in positions of power are defining value as quality divided by cost. And I think in theory, that's a decent starting point. But the issues as you get deeper, particularly in cancer care, is, what are those quality measures? And I think sometimes we put measures there because they make us feel comfortable that we're measuring value. But at City of Hope, we believe you have to start with the patient perspective. And from a patient point of view, they care about things like survival. They care about the patient experience. They care about the timeliness of care and access to care. And I think unless you have a value proposition or an equation that includes all of those, you're not really getting at value. And I believe there's an opportunity to pursue that. We just have to care enough to do that.
And why is it that so many cancer patients are not getting this high value care and not getting the best treatments, not having the best experiences and outcomes?
So I think there's lots of reasons for that. In the previous session in the poll, you just heard people talking about social determinants of health, and you can't ignore that. But I think a large reason for that is people don't understand how unique cancer is. We're at an unprecedented time in advancement in cancer treatments. We have genomics that are sort of exploding the information that's coming every day. There's new targeted therapies. And I believe that the system still treats cancer as if it's like other chronic diseases like hypertension or cholesterol, diabetes, or back pain, where things aren't changing very much. And in doing that, you kind of believe that one cancer patient is like another cancer patient and one cancer doctor is like another cancer doctor. And I think you need to start with the fundamental belief that cancer care is different. It's very hard for doctors to keep up. And unlike 20 years ago, where it truly was one specialty and you could kind of master it all, it's now like with genomics, with all the different subtypes, it's multiple subspecialties. And we need to recognize that expertise is needed, and you need access to those subspecialists and NCI centers where the literature really demonstrates that the outcomes can be better for advanced cancers. Part of it is systemic. Their health plans are creating narrow networks, and we believe they do work in other conditions where there's plenty of expertise. But if you have a narrow network that excludes an NCI center or the specialist you need to see, you may be that cancer patient that needs that clinical trial or that expert surgical capability or that new treatment that's not available elsewhere. And you're seeing this divide between the people that have access to NCI centers and those that don't.
And do you feel that this gap between sort of what you're sort of describing as optimal cancer care and the care that's more typical, is that growing? Is that because of the advances in cancer? Is that getting worse at this point?
Correct. I think cancer is one of the few diseases or conditions where that gap is actually widening. And let's talk about why it's widening, and let's also talk about the manifestations of that. It's widening because there are better treatments and there are better diagnostics that are out there, but they're coming so fast, it's really impossible. If you're a community oncologist seeing 25 patients a day of all sorts of different cancers, you can't possibly keep up with all the changes that are happening. So as you very aptly stated, the gap between what I would call optimal care and typical care is actually widening over time. And that's really important. And I want to build on the last session that our audience all heard. This is particularly a bad situation for people who are either minorities or underserved populations, because in addition to the social determinants of health, they are also the ones that typically will have the health plans with the narrow networks and have less access. And this has real manifestations. Let me just give some examples. If you look at the African American population, African American men with prostate cancer have 111% greater chance of dying of prostate cancer than their white counterparts. That's more than double the death rate. And African American women have a 36% greater chance of dying from breast cancer than their white counterparts. So the system clearly isn't working, and we're going to have to do something to improve access for all people to have access to the necessary care. I'm not suggesting that every cancer patient needs to have access to an NCI center, but what I am suggesting is that every patient that needs an NCI center expertise should have access. And then furthermore, the care they get in the community should have access to that same level of knowledge that's being generated from the NCIs and other academic or leading academic centers.
So this access challenge that you're describing it's clearly illustrated by what's happening with genomic testing and access to targeted treatments. Particularly, you told me the other day when we talked about one particular type of lung cancer where you're seeing that. Can you tell that story?
Yeah, I'm happy to. It's really a great illustration of the way the science is advancing and the way not everyone is having access. So let me tell you the good news. The good news is non-small cell lung cancer, when it's metastatic, was considered a death sentence as recently as 10 years ago, maybe even 8 years ago. But now with targeted therapies that have come to the market and the genomic diagnostics that allow you to know which target therapy to use, the life expectancy of some subtypes of lung cancer have gone from 8 months to 80 months, which is, I think the statistics were 6.8 years. So you really have an amazing turnaround. And that's the median survival. Some people do better. The bad news is of the patients that qualify for genomic testing, only 28% in a recent study are actually getting the evidence-based genomic testing. And then even those that get the testing, if you have the two most common mutations, about 2/3 of the people get the right evidence-based targeted therapy. And if you have less common mutations, it drifts down to 1/3 to 40% get the right care. So you really see this huge disparity, again, like we talked about, between optimal care and what's typically being delivered today. We really need to disseminate the information.
Yeah, so that gets me to my next question, which is how do we disseminate this best care beyond just, an NCI designated center like City of Hope to all the other places where people get cancer care?
Well, at City of Hope, we're doing a few things. So first of all, we're fighting the good fight, and if we have time for that, we'll talk about that. But we're trying to make it more evident that health plans and the narrow networks need to be more flexible. We're not saying blow up the system; it needs to be more flexible. The second thing we've done locally is we've moved from one site into 35 community sites, so we're able to deliver in the community NCI level care to cancer patients without them having to come to the major academic center. But the program that we've implemented that really has had the biggest impact is a company we spun out called AccessHope. And the theory behind AccessHope was we are and have been for decades a center of excellence, but we know not everyone can come to us. So we want to be sort of the reverse or the anti-center of excellence and disseminate and democratize good cancer care across the country. And we did that by starting with City of Hope experts. So the oncologists that are working at National Cancer Institute designated comprehensive cancer center, like City of Hope, are going to make their knowledge available to the treating oncologists across the community. So we partnered with employers first, and then now with health plans. And we said, let's use algorithms through all the data that you collect. Let's identify the highest risk cancer patients where we know the treatments will be variable and the outcomes will be suboptimal. Let's identify those patients. Let's have our experts actually review the case and work directly with the oncologist. We're not taking the patient away. We're actually enhancing the care in the community. And in doing so, we're sort of like the personal tumor board for the treating oncologist and enhancing the outcomes. So City of Hope spun out the company, and very early it became clear that this was going to be a utility for other NCI centers. So we've invited in Northwestern Medicine, the Robert H. Lurie Cancer Center, to join as a foundational partner. Dana-Farber Cancer Institute has joined as a foundational partner. So multiple NCI designated cancer center faculty are now part of a program where we're disseminating what we know out to the treating oncologists in the community, helping on the most complicated cases.
That's fascinating. Unfortunately, I think we're about out of time. Thanks again, Harlan, for taking the time to join us here today. It's been great chatting with you. I wish we could keep going. Now over to our MC, Matt Herper, to introduce our final session for the day.
Thank you, Gideon.